Good afternoon, everyone. Well, first of all, I would like to this time thank Michael Begley for preparing the coffee. Sorry, I forgot to say it all these weeks. It's very nice. Well, keep us awake. Very important. Good afternoon, everyone. Thanks for coming. It's very nice to see you. So many people today. It's my pleasure to welcome our speaker today, Lindsay Gorrell. Give you some background of her. She received her undergraduate degree, a Bachelor of Chiropractic Science in 2011 from Macquarie University in Australia. After receiving her bachelor's degree, she continued her early graduate training at the same university. At master's level, she has a Master of Chiropractic, which is a clinical program required to register as a chiropractor. She also went on to do a research-focused master degree, studying mechanical versus instrument manipulation for the treatment of mechanical neck pain. In 2016, Lindsay came to Calgary to pursue a PhD degree in kinesiology. Currently, she is a PhD candidate supervised by Dr. Walter Herzog and Dr. Jay Triano. Now, her PhD research focuses on studying the musculoskeletal biomechanical and electromyographic responses associated with spinal manipulation, and she will share some of the findings of that research with us today. Now, in addition to her academic achievements, Lindsay also worked in private practice as a chiropractor, and that experience has helped shape her current study or current research interests. Her long-term goal is to work as a clinician scientist, studying the safety and efficacy of spinal manipulation therapy, particularly at the cervical spine. Without further ado, please help me to welcome Lindsay Gorrell for her seminar entitled Electromyographic Responses Associated with Spinal Manipulation. Yes.
Fantastic. Thanks, Anquan. Before I begin this afternoon, I'd like to thank the people who have helped me on this project with both data collection and analysis. A disclaimer that this wasn't originally supposed to be included in my thesis, which I think most of you guys know I do a lot of work with human cadaveric donors. So that was supposed to continue into my second project, but as no PhD is ever as smooth as you think it will be at the start, this is now the second project of my thesis. So thank you everyone for your help with this. This afternoon, I've divided my presentation in three broad brackets. So first of all, we have a background, which will set the stage for the two descriptive studies which I conducted, one in an asymptomatic and the second in a symptomatic population with mechanical neck pain. Then from these descriptive studies, I've pulled some data for a sub-analysis. It was kind of some unexpected bonus data that we found once we were going through the descriptive studies. So I'll finish up with that this afternoon. So let's jump into the background. So mechanical neck pain is defined as being of non-pathological origin. It's reproduced with movement, and it has an annual global prevalence of between 30 and 50%. While cervical spine manipulation is an effective treatment and involves the manual application of a force to a target joint designed to take that joint beyond its physiologic but not beyond the anatomic range of motion, we're not exactly sure how or the underlying mechanisms behind why cervical spine manipulation has positive clinical outcomes such as increased range of motion and decreased pain. The literature focuses on three main mechanisms. The first being that a mechanical application of force induces transient movements between adjacent vertebrae, which subsequently alters the chemical environment both locally at the site of the manipulation and also distally throughout the entire central nervous system. These have been studied in great depth in both an animal model and a human model. So really where the gap in the literature is in the reflexogenic mechanism, which is proposed to reduce tone in hypertonic muscles. So briefly, just to describe or go through this a little bit. So on the left, we have a normotonic muscle, or a muscle at a normal resting length. This would be in an asymptomatic participant, but if we have some sort of spinal dysfunction, which can often manifest as mechanical neck pain, there's often reflex guarding or muscular contraction where the surrounding muscles tend to try and lock down movement at that joint to protect the region. When that happens, we have a reflex contraction of the muscle, and this is now its normal resting length. And the reflexogenic mechanism suggests that when we apply the manipulation, we move the joint, we stretch the muscle, and that causes a reflexic resetting of the muscle spindles, which measure speed of stretch in a muscle and degree of stretch. And we have this relaxation back towards more of a normotonic muscle at a normal resting length. So if I look at the literature and take you through the literature a little bit about reflexogenic mechanisms in this time asymptomatic populations. So this mechanism has been investigated throughout the spine, in all of the regions of the spine, by a number of authors. However, sample sizes are quite small, and this hasn't really been systematically investigated. Okay? For example, one of these studies had 11 manipulations applied, but they were spread out through the cervical, the thoracic, the lumbar, and the sacroiliac joint. So you're really only getting a couple of manipulations applied in each of these regions. However, we can collectively say that the responses, so the reflex responses associated with manipulation across all regions of the spine, are both local and distal. So what I mean by that is a local response would be manipulation applied in the cervical spine, and we see reflex responses within the neck muscles. A distal response would be that there is a manipulation applied to the cervical spine, and we see a reflex response in a thoracic or a lumbar erector spinae, or in the gluteus maximus. Now, in addition to that, these reflex responses in an asymptomatic population are very prevalent. They commonly occur. They're reproducible within participants and also between participants. The literature looking at reflex responses in a symptomatic population is, by contrast, very small. In fact, I could only find 2 studies which were directly investigating this phenomenon. So in the first, lumbar spinal manipulation was used to treat low back pain, and the authors were measuring the reflex responses in 8 back muscles in both an asymptomatic and a symptomatic population, which is why you've got the 20/20 there. More recently, over in Quebec, we had Martin Descaros's group who applied T7 spinal manipulation, and we're looking at the reflex responses in the thoracic erector spinae muscles. So in this instance, only one muscle was investigated, but bilaterally, so both sides. And when we put these together, what we find from both authors is that there was a lot less muscle response to the manipulation, both locally and distally, to what they had expected. So that brings us to sort of my rationale for this study, which was that there was been no systematic investigation into this reflexogenic response in either the neck or the upper back region. Further to that, there's been a little bit of investigation in an asymptomatic population, but absolutely nothing done in a symptomatic population or a population with neck pain. So that leads directly into our descriptive studies. And my objective for these descriptive studies was to determine the extent of reflex responses associated with manual high-velocity, low-amplitude manipulation applied to both the neck and the upper back, first in a baseline population. So our asymptomatics were in normal people, and they were chosen to really establish a baseline to see if we could reproduce the results that were already published in the literature, that these reflex responses were consistently occurring and that they were reproducible. Our hypothesis was that reflex responses would occur following spinal manipulation, and once we'd investigated this in an asymptomatic population, we then went and investigated a mechanical neck pain population. The methods for both of these studies are exactly the same. And we had a cohort of 11 in our first study, and then 19 participants with mechanical neck pain. who each received 6 commonly delivered manual manipulations by the same chiropractor who has over 30 years experience delivering these manipulations in clinical practice and who has also participated in research before. So he knows what he's doing. So to show you where these manipulations were applied, we have a diagram here of the posterior aspect or the back of someone's upper body. And we have the 4 manipulations applied to the neck and then 2 to the upper back. Now to measure our EMG responses, we were using 16 bipolar EMG electrode pairs. And I'm going to be using this schematic further on in my results. So I'm just going to spend a couple of seconds going through it just to orient you. So on the left here, we have the anterior or front view of a person. And you can see that the electrode pairs are applied to the sternocleidomastoid, so a neck muscle. Whereas on the right here, we have the posterior or back view of a person. And that's where the rest of the 14 pairs were actually placed. And we have a mixture of neck, back, and then limb outlet muscles, which we're investigating. All of the neck manipulations were applied with the participant lying supine or on their back and were elicited into, or were, I guess, applied into a lateral flexion and rotation combination maneuver. Whereas the thoracic spine manipulations, the patient was prone and the line of drive was in a posterior to anterior direction. Now, in both of these instances, we had the pedar insole, which was placed between the clinician's hands and the participant's skin. Now, what we were looking for was kind of a binary outcome. We were looking to see whether the EMG response occurred or it didn't. And to do this, we selected a threshold of 2 standard deviations above the baseline. So down here, we've got an EMG trace. We've got time in seconds on the x-axis, and then the millivolts for this channel are on the y-axis. The raw trace is the light gray, and then the average RMS is this darker line overlying the gray trace. So the RMS represents the square root of the average power of the EMG signal for a specific period of time. And basically what it's doing is it is making all of the negative values into positive. So we're rectifying the signal and then getting a magnitude from that. If I put a line in, that's my threshold line. And we also had a condition where the reflex response must have occurred within 250 milliseconds of the thrust onset, which I've just put in there in the bolded red line. Now the baseline signal, the magnitude of that was determined within the 500 milliseconds preceding that onset of thrust. To ensure that we were accurate with the timing of the onset of thrust, we used the pedar to send a sync pulse to the Windac system. And just briefly here, we've got a force time of a typical manipulation. So we have time on the x-axis, force on the y-axis. And you can see that there is a sharp deviation here from the preload force leading into the manipulative thrust. Okay, so it's the exact timing of this change here that we use to determine the onset of thrust in our EMG data. And once we had gone through and we had binary yes, no, response occurred, didn't in all of the 16 channels across the 6 manipulations in our 11 participants, we then calculated the percentage of occurrence of positive responses for each participant, and then also for each level that was manipulated. So I'm going to jump into the results now. So this is a representative result for a manipulation which occurred at C7, and this actually gave us the greatest number of EMG responses at 77%. That means that an EMG pair was activated 70% of time across all of the C7 manipulations which were given, so each of the 11 that were given. The green thatched areas represent that this EMG pair responded 50% or more of the time. The blue shaded area, the response was occurring 80% or greater, and these 2 red dots indicate that in every single participant for manipulation at the C7 level, there was an EMG response recorded. Now, pulling back from the specific level here and looking at the entire cervical spine, typically we did have reflex responses occurring in both the neck and the back muscles, and to a lesser extent in the limb outlet muscles. Remembering that this is from our first study, which had 11 participants. Now, if I move into our least responsive manipulation, which was applied to the T4 vertebrae, okay, here you can see that we do still have widespread responses across the anterior and posterior views, but we don't have as much of that 80% and 100% activation level. Across the entire thoracic spine, we did still have activation of back muscles, but we had less of an activation of neck and limb outlet muscles. T4 actually elicited a response in 64% of the EMG electrode pairs. So a little bit less than our 77 for the cervicals, but still quite a good response. This is in direct contrast to my symptomatics. So here we had 19 participants, and I just want to draw your attention specifically to, we have the same scale going up, but now we have a much lower response rate representing each of the colors. So 20% for green, 40% for blue, and then 60%, which you'll see on the next page, for red. So again, my greatest responder was in the lower cervical spine, this time at C6, but this time I only had an average of 34% activation during the manipulation, or associated with the manipulation. Now, symptomatics in cervical spine manipulation, really only the neck muscles were activated. The back and limb outlet muscles weren't really activated at all, on average. Here, if we look at the least responsive manipulation, and again that was T4, okay, now we have an activation of 21%. So instead of the 64% that we saw in the asymptomatics, we've now dropped down to 21%. And similarly to the cervical manipulations, thoracic manipulations really only elicited reflex responses in back muscles, not in neck or limb outlet muscles at all. And for those of you who know what my first project is in my thesis, you'll know I'm pretty into safety of manipulation, and I'm super happy to report that there were no adverse events in either of these two studies. Okay? 232 manipulations were applied and not one adverse event. That's pretty cool. So from what you've just seen, you can tell that there's a very clear distinction in the response rate of our asymptomatics compared to our mechanical neck pain population. That in itself isn't so exciting. I think the reasons why that occurs are a bit more interesting. So the first mechanism that I'd like to propose is that we have activation of different reflex pathways. So if you cast your mind back to the first diagram that I showed you, my asymptomatic participants, I propose, had that muscle on the left, that was at a normal tone, a nice resting length. When we apply the manipulation, we apply movement, a transient movement to the target joint, which then stretches the adjacent muscles, and we get a beautiful firing of the muscle and a good, clear EMG response. In contrast to that, with our mechanical neck pain patients, and remember that that definition is defined as pain reproducible with movement, they are potentially having irritation of facet mechanoreceptors and also nociceptors, typically fiber type C and A delta, which is providing a nociceptive and a mechanoreceptor input into the reflex. And this reflex is preferentially activated over the reflex response of the muscle. In addition to that, the manual therapy and indeed the wider literature suggests that the amount of force used in a spinal manipulation influences the EMG output that you get. So when I saw such a disparity in my results, I went back to the data and I actually looked at the force levels between the two different cohorts. And on average, in 5 out of the 6 vertebrae manipulated, my symptomatic cohort had less force put into their joint than did the asymptomatics. So I believe that that may be a factor in play here. Now, I'd just like to talk to another point, because for sure someone's going to bring it up during the discussion, that people in pain typically display a noisier EMG signal at baseline because the muscle is shortened, it's hypertonic. Now, what that would mean potentially is that with a noisier signal, the EMG response would have to increase more to actually reach my 2 standard deviations threshold. So it would, in theory, be harder for a reflex response to be positive. So I went and looked at that as well. And what I found was actually very interesting, that my asymptomatic cohort had a noisier or a higher baseline RMS than did my symptomatics. So I don't think that that is a factor at play here. It could be, but I strongly think that it actually isn't. So to wrap these descriptive studies up in a nutshell, EMG responses in asymptomatic participants are very prevalent and they're widespread, in comparison to my symptomatic cohort, where EMG responses aren't very widespread and are not prevalent at all. So moving to the third part of the presentation now, and this is kind of super exciting for me because this is unexpected bonus data that we didn't realize we could actually use from the information that we already had. So what I didn't consider when I was designing these studies and thinking about the instructions to give to my clinician prior to each study, and I should have thought about it because I'm a clinician, is that commonly in clinic, if a chiropractor doesn't elicit an audible cavitation, which is the dispersal of gas within the joint often associated with a popping sound, on the first thrust, they will often immediately reapply that thrust in order to elicit an audible cavitation. So in both of these studies, my chiropractor did just that. Okay? So on the first thrust, there was no cavitation, so no popping sound, and on the second there was. So this is a typical force time profile that you've already seen before, but it's just some raw data. So we have time in seconds on the x-axis, and then we have force in newtons on the y-axis. The bolded lines indicate thrust onset, and the dashed lines indicate the peak of thrust. So my outcomes for our biomechanic information, which is determined from the PETA, were both the peak force, up in here, and then the rate of force development from our thrust onset to our peak. Now, if we look at what I was looking at for EMG, this time I wasn't looking for a binary outcome, a yes-no. I was actually looking for peak RMS, okay, up in here. So that's the RMS at the peak of the manipulative thrust, and then the delay to onset of EMG response from the thrust onset. And both of these bolded lines here are thrust onset as determined by the PETA. So I went and had a look at the literature to see how much had been done investigating this relationship between biomechanic parameters and EMG characteristics. And what I found was quite encouraging, that there's been a lot of work done within manual therapy at a basic sciences level, so a mechanistic level. Animal models, there has been a lot of work done using anesthetized cats and manipulation applied to the lumbar spine. And there's an increasing number of studies investigating humans. But in both of these instances, a robot delivered the thrust. And really, that is great for a mechanistic look at what's going on to describe the effect of preload, rate of force application, peak thrust, thrust duration, that sort of thing. But it doesn't translate into a clinical scenario where the chiropractor is actually using the participant, using their head, okay, using gravity against them. And that's a more intuitive manipulation compared to a robot. Nevertheless, what we found in the literature is that both an increased force and speed of force application, so rate of force development, will result in an increase in EMG response. So that led me to what I wanted to do with this sub-analysis, and that's to investigate the relationship between the biomechanic and EMG responses of successful versus unsuccessful thrusts. And I did this in both my asymptomatic and my symptomatic cohort. And our null hypothesis was that there would be no difference in biomechanic or EMG characteristics between the two thrusts. The methods were exactly as I've already described because this was a sub-analysis of our descriptive studies. Okay, so that, just to refresh your memory, we had 11 participants in the asymptomatic cohort, 19 with mechanical neck pain. They received 6 manipulations, 4 to the neck, 2 to the upper back. But now we were looking for the presence of an audible cavitation or not. So of the 232 manipulations which were applied across the two trials, 52 of those, which was 22%, had actually elicited a double thrust. So Phil had applied a double thrust in almost a quarter of all of those manipulations, which I would say is probably a little bit higher than clinic, a higher rate of double thrust than in clinic, but it's in the ballpark of what I would expect. So moving into our results now, and for each of the graphs that are coming in the next 5 slides or so, we have the vertebrae manipulated on the x-axis, so our 4 neck and 2 back, and then our red bar indicates the first unsuccessful thrust, while the green bar is our successful second thrust. So here we're talking about peak force, so I have force in newtons on the y-axis here, and you can see that there was a significant difference between the two thrusts. Specifically, peak force was higher in our second successful thrust. If we now look at the rate of force development, so we have our newtons per second measurement here on the y-axis. Again, there was a significant difference between the two thrusts. Specifically, the second thrust was delivered a lot more quickly than was the first. If I looked at thrust duration, so here we have milliseconds on the y-axis. There was actually, as you can see quite clearly here, no significant difference between the two thrusts. So there was really no change in thrust duration between the two cohorts. Moving to EMG results, so now we're looking at peak RMS. So I have RMS in millivolts on the y-axis here. And we do have a significantly increased peak RMS in our second successful thrust compared to our first. If we look at delay to onset of EMG response, so we've got time in seconds here on the y-axis, you can see that there is a shorter delay to onset, which was significantly different between the second and the first thrust. So I've kind of whipped through a whole heap of slides there. So to draw it together in a nutshell, what we saw was that altering the biomechanical parameters changed the EMG characteristics, so the responses that we saw. Specifically, manipulations that were delivered with higher force more quickly elicited a greater peak EMG response with a shorter delay to onset of this response. So exactly what I was kind of expecting to see from the literature that's already been discussed. So if I bring everything together in a nutshell, greater EMG responses are seen with asymptomatic compared to mechanical neck pain populations, and biomechanical characteristics influence the EMG responses to spinal manipulative therapy. Thank you for listening to me.
Question?
Just with your secondary analysis at the end, was there any difference in the number of double thrusts between the asymptomatic versus
So interestingly, there actually was. There were more double thrusts in the symptomatic group, which really surprised me because Phil has been these people's chiropractor from anywhere from 5 to 28 years. So I would have thought that he would have known the patient better and known how much force he needed to put in to get the clinical outcome that he was after. So yeah, symptomatics compared to asymptomatics. Yeah.
So I've been adjusted a couple of times by now, and my chiropractor sometimes tells me, you know, there's a crack every now and then, but it doesn't need to be there. Now your results essentially suggest otherwise. So can I, next time I go to my chiropractor, he adjusts me, I don't hear a crack, can I tell him that wasn't right, do it again? Or is there like a more deeper relationship there?
Okay, first of all, the chiropractor wouldn't come in and tell you you're doing your research wrong, so I don't recommend you go and tell the chiropractor they're chiropractoring wrong. Just as a general sort of life advice. To answer the first part of the question though, so there's a lot of controversy in the literature as to whether the presence of a cavitation actually means that you've had a successful clinical outcome or not. And there's some studies which suggest yes it does, some that suggest no it doesn't. But there was actually a study done by Clark et al. In 2011 which clearly shows that the presence of the cavitation does actually attenuate a spinal reflex, so a spindle response. So that was kind of one of the reasons why we went with the cavitation as being successful. The second was I'm trying to really make this relatable back to clinicians. And in clinic, if you don't get a cavitation, I'm going to say 85% of us will try again immediately. It's almost like a trained thing that you don't even think about. It's just, no, I need a bit more on that, away I go. Yeah.
You should change your maybe.
Not necessarily, don't say that.
So for all the manipulations were performed on all the subjects, correct?
Correct.
And were all the manipulations deemed necessary by the chiropractor?
So that's a great question, and that is a contentious issue because I will put my hand up that 4 and 2, so 4 neck manipulations, 2 upper backs, is a big load on your nervous system in the period of about an hour. So no. This was really to see if we could reproduce those reflex responses, which are involuntary, you can't guard for them, anything like that. So where I would take these studies next, if I was to continue it, is I would be looking at dysfunction at a specific level, so maybe C2, 3, and I'd be asking the chiropractor to manipulate that level and maybe one other as a control in the thoracics or something like that. So it's a great point that you make, but yeah, no. They could have had neck pain that was in the upper neck, but they still received all 6 manipulations. Yeah.
Lindsay, could you go back to the figure where you show the increased force with the second thrust?
This one?
So the first thrust was deemed a failure. say at C1R, is it?
Yep, so
Yeah.
C1 on the right.
But when there were cases where the first thrust was successful, where did the forces fall? Were they higher, lower, in between, random?
So they were closer to the green bar. So I actually did do this analysis with all of the first manipulations, which did have a cavitation, pulled in with the successful manipulations. And the stats came out pretty much exactly the same. Yeah.
So really the failure was simply not achieving a certain
Threshold. Yeah. And that's something that I do believe. I do believe there is a threshold of force required for a successful manipulation, and that's stuff I did in my master's as well. Yeah.
What does it mean to have an EMG response? Like, I don't know how to interpret what this actually means in terms of function, or like what it does to the musculoskeletal system.
So what we're looking at here is a spinal reflex, the same as if you went to the doctor and they sit you on the edge of the bed and they get the tomahawk hammer and they tap your patella tendon and your knee goes whoop. Okay, so we're looking at a spinal reflex. So we're looking at an application of force which then moves the vertebrae, stretches the muscles, and it's the spindles that are stretched which then that information goes up, and then we have spinal reflex response. Yeah.
But what, I guess the question is kind of what does the lack of response indicate? Like in these people who are symptomatic, why is it bad that they don't have a response?
So the response will still be there, but it will be altered. So if you remember back to the first diagram that I showed, we've got the left hand muscle, which was a beautiful normal muscle, and then on the right, that's all contracted. So if you have a dysfunction at a spinal level, the muscles will guard and will become tight and hypertonic at that region. So by eliciting this response, this muscle spindle response, and stretching the muscle, we can then have a reflexogenic resetting of the tone or the tightness of the muscle back towards more that left hand, beautiful, normal resting length. Yeah. So basically we're trying to reduce pain, because if you have the muscle contracted like that, irritation of the facet joints, then that's going to be painful. Yeah. So we're trying to work out why spinal manipulation increases range of motion. Range of motion in this instance, easy. You're going to lengthen the muscle, and then you're going to be able to move more easily. The decrease in pain, that's a harder one to explain. And just to be clear, we didn't measure either of those in this study. Yeah.
Okay, to kind of directly follow up on that, so you kind of suggest that after manipulation, the resting EMG should be potentially lower than before.
In theory, yes.
Have you looked into that?
Qualitatively, yes. Quantitatively, I have not.
So I think that could be interesting to look into.
Yeah. So really with the descriptive studies, we just wanted to know if the reflex response occurred or not. That was our research question. But absolutely, that's a fantastic idea.
So then going forward on your future studies where you suggest like manipulating at the joint of dysfunction, so C3, would you expect to see an actual bigger EMG response?
I would actually argue back the other way, that the more dysfunction there is, the more pain there is, the more that the facet capsules are not happy, they're irritated. I would expect that reflex to predominate over the muscle spindle reflex, so I'd actually expect less response compared to someone who has pain but maybe not at that level, or an asymptomatic, as we're kind of stepping back away from that.
How much of the variability in peak force is driven by the characteristics of the patient versus the variability just in how the chiropractor applies the thrust?
That's a great question. So the question was how much the variability in the patient then affects the variability of the force that's applied, the rate of force development, preload, that sort of thing. So there's a lot of literature, and Walter's actually contributed most of it, showing that force application is very variable between chiropractors, but tends to be quite consistent within a chiropractor. So if a chiropractor is typically a harder adjuster or typically would use more force than a different chiropractor, they will consistently do that across a number of different patients, and that's been shown quite clearly. The variability with the asymptomatics to the symptomatics, I can't explain that, because I would have expected that Phil, having treated these patients for up to 30 years, would have actually applied less double thrusts, because he would have kind of got it right on the first thrust, if that makes sense. But absolutely the variability in force application between patients could be part of the reason why we see what we do. Yeah, absolutely.
So something I was getting from that is that it doesn't really matter, say, what build the patient would have. Like if they're super muscly and athletic versus someone frail and elderly, they're going to get applied a similar force. Is that correct?
Similar force, yes. There is modulation there, but I would argue that as long as the speed of force application is again above a threshold, that we spoke about force threshold before, but if the speed of application is above a threshold, you will still elicit a clinically successful outcome. Yeah, but say force from me to, I don't know, Anjay or Andrew, who are physically bigger, there would be more force put into those body types, but not a huge disparity from someone a bit smaller.
In mechanical engineering, there's this phenomenon called cavitation.
Okay.
And I'm wondering if I should liken the two as the same thing. So this is like something that causes damage, and it's basically due to very rapid changes in fluid.
Okay.
And so pressure, which creates a shock wave, which creates a noise, which eventually damages mechanical components, something that you want to avoid. When the neck does make that noise, is it, and you say it's like the release of gas, is it because of a rapid change in fluid pressure in the spine, or is it just one vertebral body kind of pushing on another? Like what is it? What is happening when it's when it's being cavitated? What's the word?
When it cavitates?
Yeah.
So a couple of things going on here. During a manipulation where there is that rapid thrust, yes, I believe it is due to the rapidly changing environments. I'd like to qualify that by saying that that's actually occurring within the intervertebral disc and the synovial fluid around the facet, well, more the synovial fluid around the facet joints, I'm sorry, not in the spinal cord itself, which is completely separate to that. When you, for example, cavitate your knuckles, that isn't associated with such a rapid change in environment, but it's the same thing that actually occurs. So I don't know enough about mech eng, but I would say that a good chiropractor won't have thunderbolts and lightning coming down as they're adjusting your neck and the world ends and there's a tectonic shift, as I kind of get from your description there.
I do wonder, like, my mom told me, don't crack your knuckles, it ruins your knuckles, or whatever, and I always crack my knuckles. And my knuckles feel pretty good.
Yep.
Is there any evidence to suggest that knuckle cracking is, I know this is not your field, but is there any evidence? Well, I feel like a chiropractic, if anyone, should be able to defend that cavitation is not a bad thing, so maybe you do know about knuckles.
I do kind of know about knuckles.
Okay.
So I'm not going to speak to that though, I'm going to speak to the spine. So I would argue that a cavitation produced in a hypomobile joint, so a joint that has segmental dysfunction, is a good thing because we're reintroducing movement where there was dysfunctional movement or no movement. When you're walking around and you're cracking your back, you're actually creating more movement in a joint that's already moving very well or potentially moving too much. And that isn't necessarily a good thing. So typically what happens when a spinal segment is dysfunctional and fixed, we still need to get a range of motion out of that whole segment of the spine. So the region above, the disc above, the intervertebral joint above and below will tend to move more. And they're the ones or the levels that you tend to get those cracks and clicks as you're moving kind of thing. Like I know people who can, that's not good. But if a chiropractor applies it to a dysfunctional joint, specifically targeting that joint, I would argue that is very good.
I guess that to follow up, like the majority of manipulations that chiropractor applies are to the spine.
Yes.
That's simply because there's a lot of segments that are on top of one another. Like, why is that the case, and why don't I have to, get my knee manipulated, or like another controversial one is like the hip, right, or like the SI joints. Why is it fine, and then why does it have to occur so often? Like, if I was a patient for 30 years, I'd be going, what the hell is going on? Because, well, like in the US, that would cost you millions of dollars, right? So you'd be like, well, something's wrong here. So why is this the case? And is it saying that chiropractic care isn't, these are short-term fixes for, it's like putting a Band-Aid on and it's not actually fixing an underlying issue, which would be who knows what. Like, so what is the source of these? What is the actual source of the pain of these people, and why does this provide short-term pain relief and not long-term pain relief?
So there's three things I want to talk to there. The first is why the spine. So we now need to go back in time to D.D. Palmer, who founded chiropractic, and we had a janitor who was deaf, and he adjusted an upper thoracic, and bam, the janitor could hear again, or so the story goes. So the reason why we are spine-based is to do with that is our history of where we came from, and the central nervous system, right? The brain and spinal cord controls everything, and the spinal cord is housed within the spinal canal, which is immediately adjacent to and part of the spine. So by influencing the central nervous system, it's believed that we have a greater influence over the peripheral nervous system, so arms and legs. So that's kind of the two reasons why the spine. The second part that I want to address is there are many different chiropractors who practice in many different business models. I personally see my patients once a month unless they've done themselves an acute mischief. I see a lot of softball players, they come in, they've twisted their ankle, they've banged their hip, something like that. They need a little bit more care. But I would argue that seeing a chiropractor once you are in homeostasis and doing okay, more than once a month is unnecessary. To answer the third part of that question, which was about the Band-Aid versus the long term, are you symmetrical? Exactly. So I would argue that the biomechanics of our bodies is never going to be perfect, and there are always going to be stresses placed in preferentially on one part of the body as opposed to the other. For me, it's my left SI, that if I wore a heel lift and I never crossed my legs and I never did any movements, my SI would be fine. But hey, I've got a life and I don't want to wear a heel lift, and I do movements which aren't great for my SI. So I believe that our body biomechanics predisposes us to certain issues, which unless you are going to go and get surgery to lengthen your leg or something like that, you will have that theme coming back again and again. That being said, personally I believe that exercise rehabilitation and strengthening some of those asymmetries and correcting those dysfunctions with active, patient can do at home, versus passive, comes to chiropractor fixes you, is the way forward. And it's what we should be working towards as a profession. Does
that mean that chiropractic and physical therapy care will become more similar? Like in the current age of PT, like hot topic treatments are things that are very like symptomatic. So it does somehow seem that the two of them in that case are then kind of merging almost into the similar type of profession, right?
So question to you, when you broke your leg, did you continue to see your physical therapist once a month after you'd done your rehab?
Oh, no, of course.
Okay, so there's kind of one distinction between the two professions. The next distinction is that we do focus more on the central nervous system versus the musculoskeletal system. We get there via the central nervous system. So I would argue that central nervous system trumps musculoskeletal system because it controls it. So I would kind of argue that we're maybe treating more cause rather than symptom than some PTs. Look, I get treated by a PT once every couple of months. She's great. Does that answer your question?
Sure. Yeah, I guess I could rebuttal in saying that you could make a similar argument. There are many PTs who would tell you that you should be going to see a physical therapist every few months, right? Same idea in that they have the same there's no reason to go see a doctor every few months and not go see a PT every few months because they're a better orthopedic specialist than anyone other than a physiatrist, right? So
I would argue put a chiropractor in there, but hey, I'm biased.
Yeah,
I'm biased.
Exactly. You know, I think this is a classic of like PTs hate chiropractors, and well,
I love PTs.
Yes, but they do service in a Venn diagram, the overlap is very large, right?
I feel like you're getting quite passionate about this. Maybe we should have a conversation later.
Yeah, I mean, it could be in that I have a bit of a, like, you know.
I'm waiting for it. I'm bracing. Hit me, Mike.
That you know, the way you perform chiropractic care is, you know, the way that I would view as being beneficial. But I think like many chiropractors take advantage of the fact that it's high valuation, and you can see someone very often by not actually fixing any problems. By just putting a Band-Aid over something, telling someone to come back in 2 weeks for another session that's going to cost $200.
And my response to that would be, I know a lot of medical doctors who do the same thing with drugs.
Exactly.
So within each profession, you'll have good practitioners, bad practitioners, and the majority of people will fall in the middle somewhere.
I guess I'm mostly trying to understand, there's a lot of like chiropractics, like I've known another chiropractor who's doing a PT, and he got really bent out of shape because he applied these manipulations and he didn't find anything. Like, you know, the people weren't stronger, they couldn't produce more force more rapidly, but everyone seems to like chiropractic care. And it's kind of like, well, is it then inherently bad? Like, if it makes someone feel better but it doesn't actually do anything, you know, that's basically like the pinnacle of all therapy. Is basically that, right?
Now you're talking placebo.
Yes, you know, a lot of therapy is like babysitting people and telling them they're going to be better and giving them some things that actually will help them be better.
Okay.
I guess.
Was there a question in there, or can I slide away from that one?
Yeah, I suppose.
Okay,
Yeah.
I'm going to slide.
I just wonder, you know, like, it's more of like a mechanistic thing. I think that like PT and chiropractic, like this is good that you try to like find some mechanism of why this all occurs, but a lot of it still is like, what is actually going on? What causes the people's pain?
Big black box.
Yeah.
Absolutely. Yeah. First to put my hand up to say that. Absolutely.
But yeah, like what is the source of the people's pain?
I would argue that not one of my 19 participants in the symptomatic group had the same exact cause of pain. The pain may manifest in a very similar fashion, but I would be very hard-pressed to say every single one of those had the exact same tissue and lesion. Yeah, absolutely. You make a great point.
Okay, well, changing directions away from PT versus chiropractic. On the successful, this kind of idea of applying second manipulation, I was just wondering if your experimental setup, or maybe something you have planned in the future, the factor I think maybe isn't being considered here is you've got the rate and the peak force, but what about kind of that direction and I guess the center of pressure, if you like, in relation to the underlying anatomy? Is that something you can explore with this data, or what's the focus on?
So that would be fantastic. Novell do have a glove that you can use, which would be ideal for looking at that exactly. Was the pressure applied further down the practitioner's contact, closer up towards the hand? Where was that coming? So that would be absolutely lovely. At the moment, we're working with the equipment that we have, which is the insole, which I would argue does a pretty good job. But absolutely, if I got some funding, I would be going and slashing out the 15 grand and getting a set of equipment that could do that. It would be great because it will be different. Yeah.
So Lindsay, you know, early on we talked about this, you know, this muscle that's tonically active, it's shorter, it's part of the neck pain syndrome. So to my mind, the only way a muscle can be shorter is if it's active. So, and I know you have the descriptive, calling these descriptive studies, but you have the data. So I'd like to know how big the baseline EMG is in your neck pain patients prior to the manipulation to show that actually you are hitting the shortened muscle that's tonically active.
Yep. So I can give you the average. So for my symptomatics, it was 0.015 millivolts. And then for my symptomatics, it was actually less than that at 0.0045 millivolts.
What does that tell you about the model, which says that the muscle is shorter and hyperactive, essentially hypertonic? I think it is.
So I would argue that what I've just said actually doesn't show that. It shows the exact opposite. Now, the reason that I think we have this phenomenon is that you're looking at, in my asymptomatics, 10 out of the 11 participants were naive to spinal manipulation. They had never had a spinal manipulation. They had never met Phil before. They weren't sure what was going on. For some of them, it was like 6 o'clock in the morning and they're in here and it's kind of what's happening. So there's an anxiety, even if they didn't overtly show that I believe has been clearly shown that does actually increase your baseline EMG. Whereas with my symptomatics, they've seen Phil as patients for 5 to 28 years. They know exactly what's going on. It's in their normal clinic. They know what to expect. They've had beneficial effects from spinal manipulation before. So they're really primed towards, I'm comfortable, I'm relaxed, I know what's going on, this is going to help me. So their anxiety is marvelously just depressed. So that's why I think we see the opposite of what you would expect to see, based on your question. Does that answer your question, Tim?
It does, and I'm not sure I buy it. But because I think that possibly lying, if they're comfortable with being in the clinic, perhaps their tonic EMG levels drop.
Yep.
Or perhaps it has to do with the position. Maybe when they're walking around in everyday life, maybe these muscles are active. And that their neck is sore because they're holding up their head. But when they're in the clinic,
they're in an anti-gravity position.
Down
yep.
And they're in the clinic, they think that the problems are going to be solved because chiropractic works in the clinic. So I'm just wondering if really, do you think that in real life they do have this overactive drive to their muscles, which causes them to be short and causes the pain, but in the clinic it's simply a situation where that's temporarily abolished?
That is very possible, absolutely. And definitely what you were saying from going from a gravity position of having to hold your head up, which is very necessary for survival, to keep your eyes level on the horizon, versus anti-gravity, whether they're supine or prone, that's a huge thing. I still would have maybe expected, because the symptomatics had the exact same methods as the asymptomatics, so I still maybe, to fully buy into that, would have liked to have seen the numbers the opposite of what they were, but definitely a possibility.
Well, you said it was 0.15 millivolts of baseline actually, and that's nothing.
Nothing. Yeah. 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 No, I agree.
Kristen.
Hey.
So you mentioned that you were happy to see that there were no adverse events.
Yep.
How common is an adverse event? And then kind of what is it too much force? Is it technique? Is it position? What causes adverse events?
So the second part of that question, I can't answer. I don't believe that anyone can reliably or honestly answer that. To answer the first part of the question, transient, mild adverse events such as muscle soreness, you might feel a little bit dizzy as soon as you sit up or pop up from the table, very common. They're transient, they pass within seconds to 24 hours. Moderate adverse events, now we're talking about something like someone actually falls over after they've got up off the table because they were dizzy. They maybe have a muscle strain that takes maybe a couple of weeks to heal. Less common. The severe...
What is very common? 8 out of 10? Or?
Oh goodness, no. Maybe 3, 4. Yeah, 3, 4 out of 10. Yeah. Severe adverse events, so your vertebral artery dissection. 1 in 10 million manipulations. Yeah. Yeah.
And they don't really know, like it's just kind of a case-by-case basis.
Yeah. You weren't in the room with the chiropractor. You don't know whether the patient was actually undergoing the vertebral artery dissection, which presents exactly like neck pain can, mechanical neck pain can. You don't know if they were in the prodrome of about to start that process and they could have just turned their head and the movement actually caused the dissection. We don't know. I will say from the preliminary results that I've got on the cadaver work that I'm doing, that a healthy artery cannot be dissected by a manipulation, by a cervical manipulation, a healthy artery. It's not mechanically possible.
Is there like an increase? So you look at two, like with the sound and no sound, successful versus successful. Were there a 3 to 4? Like that's
a no-no.
That's a no-no.
Yeah, if you don't get after 2, then often what will happen is you'll go and do some ancillary work, so you'll do some soft tissue work, some mobilizations, and then you might go back at the end of treatment. But I've never ever seen a chiropractor in, what was I, 5? So, I don't want to say how many years, but a lot of years. I've never seen a chiropractor attempt a manipulation 3 times. It could happen though. I've just never seen it.
I want to follow up on Tim's question. So you give a global average, but presumably not all the muscles will be affected. Did you look at affected versus unaffected muscles?
I have not done that yet, no. Yeah. That's something I should be doing. Absolutely.
Any questions from the web? Or no? Or if not, let's thank Lindsay.